presentation, I would like to welcome our guest presenter, Lucy Zhang. Lucy is a member of BKD National Healthcare Group and provides consulting services to post-acute care and hospital providers. Her services include reimbursement consulting, care redesign, and process improvement. Prior to joining BKD, Lucy was a registered nurse for 3 years. So without further delay, I'll hand the call over to today's guest presenter. Lucy, please go ahead.
Thank you, Nikki, and good afternoon, everybody. Thanks for taking the time out to listen to this webinar about the cardiac bundle today. As Nikki mentioned, I am a nurse. I'm speaking to you today out of our beautiful St. Louis office. So I started my career here, but was also lucky enough to do travel nursing about 1.5 years, which took me to Texas and a couple places in Los Angeles area. Have worked as a telemetry nurse, but pretty much everywhere else as a float pool as well. So that took me to ortho, oncology, so every type of floor nursing that you can think of. We do have a ton of content to get into today, so we'll go ahead and get started. And we'll begin by the ruling overview and the key implications. Then we'll really dive into the weeds and go into the key elements and mechanics that are really important to hospitals of this ruling, and then we'll leave about 10 minutes for questions and answers. So I hope you all have something delicious in front of you today, because we do have a lot of content to cover, about 1,600 pages ruling, or 500 pages depending on which version or font size or spacing that you use. But I do want to take a few minutes to talk about kind of the political uncertainty that's happening right now, because a lot of you are probably still wondering and might be waiting to act because the future really is uncertain. We finally have a president now, but it still feels like we don't know what's going to happen, because the Secretary of Health and Human Services, Tom Price, pictured here, has been an outspoken critic of the mandatory bundles because he thinks CMMI, or the Center for Medicaid and Medicare Innovation that rolls out the bundles, that he thinks they've overstepped their authority when they implemented these rulings. However, during his confirmation hearing, he also spoke quite favorably about CMMI and stated its great possibility and great promise. So we'll see what he does since he's kind of has all this authority now as the boss of HHS and is on the other side of the perspective. The latest update, I'm sure as all of you know, the final ruling has been delayed from July 1st to October 1st. CMS is further taking comments to further delay until January of 2018 to align with the fiscal year. And if I was a betting man, I would think that the January date is probably more likely, because it'll just be so much easier to start then than start in January, rather than only having 3 months be the first performance year of the program. However, I see these delays really just as a hiccup in the long journey towards value-based reimbursement. And the best time for hospitals to act really is now, because this is here to stay, and it's going to come at some time. Because from the ACE demonstration to the BPCI program, CMS has been gradually tying more payments to patient outcomes for the last 12 years, and they've seen some positive results and have had bipartisan support. So they'll continue to shift risk towards hospitals. And for hospitals, this shift requires such a fundamental change in the way you deliver care that I really believe you couldn't start soon enough. It takes a lot of time for an organization to do things like adopt best practices, standardize care pathways, gain organizational alignment, and build those post-acute and IT infrastructure networks that you need to succeed. So those who get an early start, it's going to be much better off. So the high-level view is that these episode payment models, or EPMs, created 4 new models that you see here. Those 2 in the red box on the left are what's commonly referred to as the cardiac bundle. So that includes the acute myocardial infarction, or AMI, which is those 3 AMI DRGs, but also includes 6 DRGs for PCI, or percutaneous coronary intervention. That's only if those PCI-DRGs have an AMI diagnosis in the principal or secondary position, because they don't want to include PCI episodes that were used for intracardiac procedures, such as cardiac ablation or cardiac mapping. The coronary artery bypass graft, or CABG model, includes 6 different DRGs you see here. The cardiac rehabilitation incentive payment model is a post-acute model meant to support patients and increase the usage of CR for patients who've had AMI and CABG episodes. I'll cover that at the very end. And lastly, the EPM also expanded the CJR model that began in April last year to include 3 DRGs that are for the surgical hip and femur fracture treatment, which is abbreviated SHIFT. I will not really cover that today, but good to know that the model also modifies CJR and a little bit. And like CJR, the cardiac models span over 5 years, and an episode includes the inpatient stay and ends 90 days after discharge. So this is perhaps one of the biggest challenges I see with these mandatory bundles, is how do hospitals follow up with these patients for 90 days after their discharge. Hospitals might be used to following them up since the hospital readmission reduction program began in 2012 for 30 days, but 90 days is really quite a bit longer. And in the timeline below, we can see how the orthopedic and cardiac bundles overlap, as well as when downside risk began for the EPM. So as you can see, mandatory downside risk starts in January of 2019 right now, but this is likely to get pushed back since the implementation date for the entire model is delayed. So this is good news for providers, as it gives you a little bit more time to implement changes without having to owe money to CMS for performance. This included services and items list literally unbundles the bundle and shows you exactly what kind of things goes into the cost of the acute care and the 90-day post-discharge period. As you can see, most of the services occur outside of the 4 walls of your hospital, such as SNF, home health, outpatient, DME, clinical lab. So this is very difficult to manage, because that's like handing a credit card to your patient when you discharge them from the hospital and giving them free reign of that card for 90 days after, and you getting a bill a few months after that, and you can finally see what they spent your money on. So as a hospital administrator, I'd start thinking about how do you collaborate and incentivize these post-acute providers to keep costs down when they're still operating under the same fee-for-service model. And Medicare estimates that 73% of healthcare spending variation comes from the post-acute phase. So if you're able to successfully collaborate with these post-acute providers, that's going to equal a lot of savings and help you be very successful in the bundle. So that's, to me, like the lowest hanging fruit. Looking at the excluded list, there are instances for which hospital readmissions are not going to be counted towards that bundle, such as oncology, trauma, or surgery that's not related to an AMI or a CABG. However, as you can see, that list on the right is much shorter, and that's certainly the direction we're getting from CMS, is just assume everything is included in the bundle. A simple way to sum up the financial accountability is that the EPMs operate under a retrospective and 2-sided risk models, with the hospital bearing financial responsibility. So how this works is that throughout the year, hospitals and other providers will be paid per normal under the same fee-for-service model. But at the end of the year, CMS will conduct a reconciliation process where the hospital's performance will be compared against a quality-adjusted target price. If hospital spending exceeds the target price, then that hospital owes a repayment to CMS. But if your spending is less than the target price, then CMS will give you a reconciliation payment. Those target prices, as we'll see later, have a maximum built-in 3% discount off of the historical benchmark prices, and that's how CMS gets their cut. They estimate that they will save about $50 million at the end of the 5-year models for AMI and CABG. So for those of you who are already in CJR, you should have gotten your reconciliation reports a couple weeks ago. So that'll give you a good idea of how how it's calculated, how it's operating going forward. So which hospitals were selected? 98 MSAs or metropolitan statistical areas were randomly chosen to participate in the cardiac bundle. That's about 1,127 hospitals. And they're pictured in red here. The CJR and shift model, the shift DRGs are expanded to the same 67 MSAs that CJR is already implemented in. As you can see, the number of hospitals is not exactly the same. And 17 very lucky MSAs, Denver being one of them, were chosen for both orthopedic and cardiac bundles. And those are shaded in the blue color here. And that's about 195 hospitals. And just to give you an idea of how prevalent this is, there are 374 MSAs in the United States, 148 out of which have been chosen. So about 40% are now will be subject to mandatory bundles once this begins. And even if you've already had experience with CJR or BPCI, I do want to point out some challenges that are going to be unique to the cardiac bundle. The most important of which is that AMI and CABG patients have more chronic diseases, higher rates of mortalities, and readmissions. So these patients are going to be sicker, more expensive to care for, and more difficult to keep out of the hospitals. I would start looking at how to engage patients to manage chronic diseases such as hypertension and cholesterol, all those risk factors for cardiac disease, because that's really the way to keep patients out of the hospital. And we keep talking about how the importance of doing preventative care, and now I'm hearing a lot about incremental care. Under the bundle, these things are very hard to do because you're asking your patients to change their lifestyle. But under these bundles, the hospitals are going to be a financial risk if your patients don't start changing their lifestyles. The AMI bundle is also the first mandatory one to require significantly different clinical pathways, such as if you have an AMI, you could be treated medically or interventionally with PCI. So that means there's going to be a lot more variation in the care pathways that exposes you to greater risk. So if you look at your processes, I would start asking questions like, do your physicians always order the same labs and tests for someone who comes in with chest pain? Does your interventional cardiologist perform different procedures, such as radial approach versus femoral approach? And if so, why? Is there any reason to it, or are they simply doing that because they're used to it versus doing the evidence-based care pathway? If the answer is no, then you have a lot more opportunities to achieve savings by standardizing what tests are ordered and how your patients are treated. And the AMI episodes are always emergent cases compared to orthopedic bundle. It would be nice, but your patients aren't really going to call your ED and schedule an appointment for a heart attack in a month. So you don't have the opportunity to sit down with your patient prior to the hospitalization, to set expectations, discuss the plan of care and the discharge location before they're very anxious or in pain or worried about their financial situation. This also leaves more variation and risk. Hospitals may not offer all the services required to treat an AMI, so you might have to discharge them out for a higher level of care. And lastly, about 3/4 of a CABG episode spending occurs in the acute care phase. So while this means you do have more control over the episode costs because it occurs within your hospital, it's going to be more difficult to achieve savings at the same time because, like I said, post-acute is the biggest area to achieve savings. Okay, so now I'm going to really dive into the key mechanics, and I want to tee this up by saying that there's a lot of content in this ruling, so many of the slides here are going to be reference slides for you that I will not read over, but I'll kind of talk about what the slide is and tell you what the most important thing to know is. I'll start with the major changes from the proposed rule to the final rule, talk about the transfer policies, go over how to calculate a composite quality score, talk about how benchmark prices are set and look at a calculation for reconciliation and repayments, talk about collaborators and gain sharing, the waivers that the EPMs created, and lastly cover the cardiac rehabilitation incentive model. Major changes from the proposed rule. So this is not one of the ones I will go over. If you're familiar with the proposed rule but are wondering what came out with some of the things, this is a good reference slide for you. So the transfer policies initially from the proposed rule caused quite a stir, but a lot of you will be happy to know that the final rule can be easily summarized in the line that you see below. So if you're a participant hospital and you do not admit or discharge the patient, then an episode will not occur. So that means that episode will not be counted as in the reconciliation process afterwards. And this is a very beneficial change from the proposed rule so that hospitals that initially treat the patient will no longer have to bear the costs of the services that another hospital spends if the patient needs to be transferred out for a higher level of care. So you can see that in these fourth and fifth lines here in the two inpatient to inpatient transfer scenarios. If you are a participant hospital, you admit the patient, but then realize they need a higher level of care, and you send them to a non-participant hospital, then the episode is canceled for you, and that hospital will not have an episode since they're not a participant. In the second one here, where you admit the patient but transfer them to another hospital that is a participant hospital, the episode will still be canceled for you, but an episode will start for them. So I hope that makes sense. But there is a caveat to this, however, and the example I want to give is that if you admit a patient for AMI, stabilize them, discharge them to a home or SNF, another outpatient setting, but that patient later on needs a CABG and decides to do it at a different hospital, the costs incurred at that operating hospital and the post-acute care that hospital suggests will be attributed for you since the AMI episode began with you. And the reason this is because this patient was discharged home first. So since they were discharged, this transfer rule does not apply. So if you're a smaller hospital that treats AMI but does not perform CABG surgeries, it would be great for you to refer to the patient to a high-quality hospital for surgery, as well as follow that patient during and after their discharge from the operating hospital since, like I said, they're still kind of spending money on your credit card. The quality is extremely important in these bundles, so I do want to take the time to go over in detail. These are the components that make up the composite quality score for the AMI and CABG. As you can see, there's a voluntary measure for each of these. I want to take a look at walk us through an example of how the AMI composite quality score is calculated. Let's start at the top. We can see that there are 4 different quality measures that make up the composite quality score, and those are 30-day mortality, AMI excess days, HCAHPS, and keep in mind that's HCAHPS for your entire hospital, not just your AMI patients. And then the last one is a hybrid AMI mortality, which is a voluntary measure. The weights of those are below. Your patient outcomes is always weighted 80%, and then your patient experience is weighted 20% for all the different, for CJR and the cardiac bundle. So what CMS will do is take your performance and compare you against all the hospitals in the country and place you on a percentile. In this example, this hospital is in the 50th percentile, so that gives them a 7-point for this. If they, let's say they also performed the 50th percentile for AMI excess days, they get 2.8. They did a little better in HCAHPS, so they got 3.1. That gave them a composite quality score of 13.2, which puts them in the good quality category. And you can see the range and breakout down here. However, if they had taken the time out to submit the voluntary measure, they would have gotten 2 extra points, and they would have been in 15.2 and put in the excellent category. And we'll talk about later on why that's so important to get those extra points if it'll put you in the next quality category. A couple other little details to know is that you can get additional points for improvement from the previous year. You can see those up there in the parentheses. And if you don't have enough surveys to have a score in each of these quality measures, you'll automatically be placed in the 50th percentile, which, as you can see in this example, is not very a big punishment, as this hospital was still kind of on the high end of the good category. I do want to dive into the voluntary measure of hybrid AMI mortality because it is very unique. It's the first one that requires hospitals to pull data from their EHR. What the one is the patient's age, heart rate, and systolic blood pressure. And these two, they want those that are first captured within 2 hours of presentation to the hospital. They also want a couple labs, the patient's troponin and creatinine, that are first captured, measured within 24 hours presentation to the hospital. However, CMS does understand that since troponin is not in the regular CBC or BNP panels and other emergent interventions might need to take place rather than drawing troponin, they'll excuse a hospital if you do not draw a level in the first year of the program. So you can still get those 2 extra points if you don't draw troponin. However, that's not excusable anymore from year 2 and going forward. And you only need to submit data for 50% of your AMI patients in 2017, but that quickly ramps up to 90%. So like CJR, it's good to kind of get some experience because the required data kind of ramps up very quickly. The CABG composite quality score is calculated the same way, so I won't go over it. I do want to point out this 30-day mortality measure is worth 70% of the entire score, so that's going to be very important. And here are the range of dates that your quality scores are pulled from in order to make up those quality measures. As you can see, for these 3, they go back very far. They go back 3 years. So what I want everyone to remember is that if your quality measures aren't where you want them to be right now, it's very important to put in processes and start talking about how you can bring those up, because that can affect your scores about 3 years down the line. One of our hospitals that did well in CJR reconciliation had actually a very poor complication score for their TKA, and that was only because they had different surgeons and different processes 3 years ago, and they were surprised, but once they realized it was from a later date, it made sense to them. So here's why quality matters so much. Each of those quality categories, the good, excellent, acceptable, translates into an effective discount factor. So that the higher the quality score, the lower the discount factor, which means that you'll get a higher reconciliation payment from CMS, or you owe them a lower repayment amount. I want to look at this table here. So if you're in the acceptable category, you get that normal 3% discount. But if you do better and you're in the good category, CMS is only going to take 2% off of your historical prices. If you're in the excellent category, they're only going to keep 1.5%. If you're in the below acceptable, however, you don't get any reconciliation payments, even if you perform below the target price. So now I'm going to really dive into the financial piece. Again, this is one of those reference slides. I won't go over it, but good definitions for each of these key factors. And generally, the benchmark price is going to be set with the exclusion of special payments such as DISH and IME. And then another break that CMS kind of gives you in calculating the reconciliation is that if you have an episode, let's say your patient was just very sick, was in ICU for 15, 20 days, went septic, and cost, say, $100,000 for that episode, they will cap those high payments at 2 standard deviations above the regional mean before calculating the NIPRA. So your benchmark prices are set, your benchmark prices are your target prices before applying the discount factor. And they are set by each DRG, which there are 15 of in the cardiac bundle. However, they are going to use the limited risk stratification strategies and allow for additional spending for patients who are a little bit more sick. So if your AMI patient comes back with a CABG readmission, they're going to give you more benchmark set a higher benchmark price for that. Or if you have a CABG patient with an AMI diagnosis, they're also going to give you more money for that. And the key thing I want everyone to remember is that this is a much more complicated financial calculation than CJR, because there was only 4 benchmark prices for CJR. By my calculation, this method would result in 74 different benchmark prices. And also, when I say limited risk stratification, that means it's not taking into account other things that make your patient more complex and more expensive to care for, such as chronic conditions or HCCs or their socioeconomic status. So that kind of falls on the hospital to do their own risk stratification strategies and figure out how to care for these sicker patients without going above the target price. Your benchmark prices are also set by a blend of your own historical performance and that of the regions. So as you can see in the diagram below, this blend starts at 2/3 hospital historical price and 1/3 regional price. That quickly shifts into 100% regional in performance years 4 and 5, so that you're essentially competing against yourself in the beginning of the program and then competing against the region at the end. The region is also defined as U.S. Census regions. So you can see this map here, very big. For those of you in Region 10, your average has to be compared against those in all those 8 states here. And the shift from hospital to regional performance can mean that you may be doing well in the first 2 years, but then once you're being compared against the rest of the region, maybe you're not doing as well. So I would start benchmarking myself against regional performance early on, so it's not as big of a surprise. The payments you receive from or owe to CMS are also going to be subject to stop loss and stop loss limits that are summarized in this table here. It's going to make a lot more sense when we go over an example, but I do want to point out that if we have any smaller hospitals, such as rural, so community, Medicare dependent, and EPM low volume protection hospitals on the phone, you guys get a much lower stop limit, because CMS understands that the smaller hospitals has less resources to implement care redesign processes, so didn't want to restrict as much. And EPM low volume protection hospitals are defined as the hospitals who have AMI or CABG volume at 10% or below of the other hospitals in the MSA. And I do want to point out that this is not hospital specific, it is model specific. So if you have low volume for CABG, you can be an EPM low volume hospital for CABG only, but be subject to the regular limits for AMI if you have enough episodes for AMI. Okay, finally, let's look at how all those discounts and limits come together. So let's say number 1 hospital had a benchmark price of $24,000 for DRG 280, which is AMI with MCC. They performed in the acceptable quality category, so they have a 3% discount. That gives them a quality adjusted target price of $23,280. And let's say they had 2 episodes, one at $22,000, one at $28,000. The NPRA, or net payment reconciliation amount, is the difference between the actual spend and the target price. So for Jing Do, the episode did well, was below the target. However, John Smith went over, so his was negative. And CMS will take all your episodes like this and aggregate the NPRA. So we'll just do 2 for this example, but their aggregated NPRA turns out to be negative. So this NPRA is how much you would owe to CMS if it wasn't for the existence of stop loss or stop gain limits. But we have to calculate those limits since those are in place. Your stop loss limit, let's assume we're in year 3. Let's assume it's 5%. That's going to be taken as 5% of your aggregated target price. So that's the $23,000 times 2 episodes total. That's $2,328. So this is the actual amount that you owe to CMS, even though you performed lower, because this is less of amount that you have to pay. Next, let's look at another example of how two hospitals with different quality scores fare. Here we have number one hospital again. Both of them and number two hospital, they both have, again, that benchmark price of $24,000. And they both have an episode that costs $23,500. So they have the same performance. Number one hospital is in the acceptable quality category, 3% discount factor, same quality adjusted target price we saw earlier. So their NIPRA for this one episode is negative $120. So that's what they owe to CMS. However, because number two hospital performed in the excellent category, they had a lower discount factor, which gave them a higher quality adjusted target price that ends up giving them a positive NIPRA. So they'll end up receiving money from CMS. So this is why I think quality is so important and why it is worth the time and resources to invest into getting those quality scores up and also filling out those voluntary measures. Because if you are eligible to get bumped up in the next category, it can mean the difference between owing money or paying owing money or getting money back from CMS. To share some of the risks and gains we just calculated, CMS does allow hospitals to enter into collaboration and gain sharing arrangements with other providers that are listed here on the left. And these are the general rules that you can that you have to abide by if you do gain share with them. So as you can see, a lot of these are the post-acute providers you see here. And CMS does want you to partner up with them and build a preferred network, a preferred provider network, which a lot of you have probably heard that term before. But they are very strict about not restricting the beneficiary's choice at the same time. So what this means is that if you have 3 SNFs in your area that you have vetted and you believe have high quality for your patients, your case manager could absolutely do a little bit of soft steerage and recommend those 3 SNFs to your patient should your patient need a SNF. But at the same time, the case manager must also provide a list of all the SNFs available to that patient, and the choice must ultimately be left up to the patient. And in order to expand access to lower cost services, CMS also created 3 different waivers to go along with EPM. If you are familiar with CJR, these will probably look familiar to you. You have the same waiver for the SNF 3-day stay. I do want to point out that this waiver is only for AMI and not cabbage or shift. And this is because CMS looked at the average inpatient length of stay for cabbage and shift and found that they were all much longer than 3 days. So they felt like it was not necessary. You also need to, the waiver only begins also after a certain date. Right now it's October 4th, but again, might change. If you discharge a patient to SNF earlier than this, thinking that it applies, or if you discharge a cabbage patient to a SNF earlier than 3 days, thinking that the waiver applies, then your hospital might be liable for that SNF payment. So very important to talk to your case managers and make sure you're following the rules. The telehealth waiver might be a good one if you have a lot of rural patients, because it'll give them that extra visit with a healthcare provider without having them ask their family member or friend to give them to drive them very far away to see them. So I would be, you can think about how you can integrate these waivers right now into your care redesign process. So if you had a patient who perhaps needs dressing changes only, but now they can go, they qualify for a home visit waiver right now, that they don't need to go to a SNP to get those dressing changes. And the home health is probably a better option for them anyway, since they don't need rehab. So however, you should really look at what the best place of discharge for your patient is, because if you do push your patients out too early or push them to a lower level of care when they really do need a higher one just to save money, then that patient might end up getting readmitted. And a readmission is almost always going to put your patient above the target price. So No matter how much you do, though, patient compliance, as we all know, is key. If you send them home or send them to a SNF and they don't take their meds or understand their disease process, then unfortunately they're just probably going to end up back in the hospital. CMS did allow some engagement incentives in order to help your patients, and you can give them up to $1,000 per episode as long as it's reasonably connected to the episode of care, so connected to AMI or CABG, and also as long as it advances one of the 4 clinical goals that you see on the right side there. Some hospitals are lending their patients iPads or iPhones or iWatches, so it can help them track their heart rate. You can send them a text message to remind them of an appointment. So technological incentives that are $100 or more must remain the property of the hospital, and you must get it back, and there's some documentation rules surrounding that as well. Okay, but lastly, I want to wrap up by talking about the cardiac rehabilitation incentive model. And this, CMS really created this because this is a very underutilized service right now for AMI and CABG patients. I think especially for AMI, some of the data I've looked at shows that 100% of CABG patients are absolutely referred to a rehab program, but not necessarily AMI patients. But research has historically shown that there's about a 25% reduction in mortality if a patient completes a CR program. And they also have much improved quality of life as well, generally. How this incentive model works is that a hospital will get paid $25 per session for the first 11 CR sessions, and that quickly jumps up to $175 per session for each subsequent one. And assuming the already limitation Medicare has for CR, patients are allowed 36 sessions over 36 weeks. So assuming that 36 sessions, they are eligible for, your hospital is eligible for $4,650 total incentive if your patient completes cardiac rehab program. And key thing to point out is that your patient does not need to get cardiac rehab at your hospital in order for you to receive this benefit. So even if you don't have a CR program, you can receive this incentive. As long as your patient has been discharged under AMI or CABG model and they're a qualified Medicare beneficiary, your hospital is eligible to receive it. So even if they go far away, you can still get it. 90 MSAs or metropolitan statistical areas were chosen for this cardiac rehab model. 45 of them are actually in EPMs or the cardiac bundle, but 45 MSAs are not. And CMS wanted to do this because they wanted to test to see if the bundle increases the cardiac rehab utilization or they don't. And that affects about 1,100 hospitals total. Waivers and incentives were also created for cardiac rehab in order to expand the access. The definition of a physician has been expanded, or actually waived, to allow a physician assistant, a nurse practitioner, or a clinical nurse specialist to prescribe cardiac rehab and its prescribed treatment plan. So that could be break down a barrier for a lot of your patients. And same as the beneficiary rules, incentive rules we saw earlier, CR hospitals can also give their patients up to $1,000 and give them, Fitbits and iPhones and stuff like that, as long as it helps them complete their sessions. And CMS really recommended using this incentive to provide transportation for your patients. So if you do have a lot of patients living kind of far away from your rehab facility, you can absolutely hire a shuttle or even pay for their Uber ride to pick them up and take them to your facility. Unfortunately, hospitals cannot use this subsidy to pay for the patient's copay. And unfortunately, that could be a barrier to a lot of patients continuing with cardiac rehab, but they left this pretty broad, so there could be lots of other ways to use this incentive to help your patients get through the sessions and improve their health. So I think given the research, motivating and incentivizing your AMI and CABG patients to participate in cardio rehab is a huge opportunity to improve your outcomes, reduce readmissions, and good for your bottom line. So I'd start looking at what my referral and utilization rates are for cardiac rehab. What are the main barriers to cardiac rehab completion for my patients, and how to use these incentives to break down those barriers. Okay, so we are done with the key ruling. Everyone can take a deep breath. So what do you do now? These are the 8 strategies that CMS has recommended hospitals do for care redesign in order to be successful. And I won't go over each of these, but as you can see, coordination is a big deal. And like I said, most of your saving opportunity is going to be that post-acute phase. And if you're feeling a little overwhelmed, what I absolutely think you should do is really just by start analyzing your data, because that's going to help you identify your high cost areas, identify variations in your process, benchmark yourself against best practices, and help you create a preferred provider list so you can see who in your post-acute network has traditionally been less expensive and higher quality. Unfortunately, the data is not yet available for the cardiac bundle. CMS, their last update was that they'll be available by mid-spring to cardiac rehab and EPM participants. And if you haven't already requested data from them, you can go ahead and shoot me an email, and I can give you the information on what to write to CMS to request data once it does come out. Other things you can do is to identify a physician champion and build a team. Physician buy-in is key to this ruling because they're the ones putting in orders and they're the ones that's spending a lot of your money. And that message of which physician is doing well, how you get them to change their practice really comes through a lot better from another physician. So if you have someone internally who can, you can educate and get on board as kind of the change champion, that's going to be very important for success. I would start developing relationships with post-acute providers and develop a risk assessment tool and a system that works for you so you can identify your high-risk patients and the ones that you need to follow up with more. For CJR, we've seen the WRAPT tool work very well for a lot of our clients. And lastly, educate your staff and get their input and buy-in. And as a nurse, I'm probably a little biased, but I think your nurses can help you a lot provide better patient care and better outcomes because they really know your patients the best. Sometimes your doctors might know what's medically going on with your patients more, but your nurses really understand your patients as a whole. So get ideas for them, educate them so they know what's going on and why you're changing processes for them. And with a few minutes that we have left, I want to just show us some examples of how data can help you in this bundle. So this is a dashboard that we modeled up for the cardiac bundle. You can look at your patient demographics, see if your patients are older or younger, which of them more, I think for cardiac, probably a lot of hospitals are going to have more males. See if the episode is more expensive as your patient ages. You can compare year to year, see how that trends. You can see where your patients are coming from, where they're going. Are the ones who are living far away from you really more expensive to care for? Your hypothesis is probably yes. Look at how your volumes are trending by each DRG or each DRG grouping. Look at how much breakdown is between each of your episode spend. So the blue color down here is your inpatient. But as you can see, for AMI and PCI, a lot of that is in the post-acute area. But as you can see also here, as I mentioned, only 3/4 of CABG spending is in the inpatient. So this bar is a lot higher for that. Look at if your episodes does go above target price, what is causing it to go above? It looks like there's a lot of readmissions for this hospital. Some outpatient costs. You can dive into each of these patients if you do see an outlier by going through looking this scatter plot. So what we have is each of these is an AMI patient. The colors are by each DRG. So if we just look at AMI with MCC, that's going to be your highest acuity patient. So as you can see, the average episode total is a lot higher. The O's are patients who did not have a readmission, but the X's are the ones who did. So as you can see, as we go up in episode cost, it's a lot of readmissions that are causing it. And we're seeing a lot more readmissions compared to CJR patients as well, about 25-26% readmission rate. If you do have a very expensive episode, you can hover over it, look at the tooltip, see what was it that drove that readmission or drove the episode to be so expensive, so kind of manage by exception. If you plot each of those patients along the a box and whisker chart, you can quickly identify which of your DRGs has the most variation in terms of cost. So for cabbage, as you can see, this box and whisker is the distribution. So even though your distribution is kind of high for cabbage with cath with MCC, not a lot of outliers. They all fall kind of within this range. This is your median cost. This is the upper 25th percentile. This is upper 75th percentile. Only one outlier here. But once you get to your AMI, a lot more outliers. And this is really points out the variations that I was talking about earlier with AMI. What are you doing for these patients? Are some of them being put on a heparin drip? Are some of them just on sub-Q Lovenox? If so, why do they get these different anticoagulants? Is it just because some doctors prefer it, and etc.? You can look at where you're discharging your patients to. For CJR, that was a big focus in reducing costs, is trying to get your patients home with outpatient therapy versus sending them to a skilled nursing facility for rehab or to IRF for rehab. And then you can look at your post-acute providers as well. Look at your, in this example, there's just 4 SNFs that this hospital discharged to. Look at which ones have the lower lengths of stay and the lower payments. And then which ones are the circle, the size of the circle denotes how many admissions they had. So which SNF are you sending most of your patients to? And is that a good one in terms of length of stay or a payment? You can take this to your post-acute providers and start having a conversation with them. Say, hey, I want to partner with you, but you need to improve on this, and why aren't you doing as well as your competitors over here? Okay, so I hope that was helpful. I'm going to turn it back over to Nikki for any questions.
Great. Thank you so much, Lucy. I mean, what a great blend of high-level and practical information. So great job there. Before I take our first question, I would like to remind everyone to type their questions into the questions panel, which is located to the right of your screen, and we'll take as many as time will allow. I will address one question right off the back about accessing the slides. So if you missed the intro, you can access the slides right now by going to the handout section, that floating panel to the right. Expand that and then click on that PDF icon, and you will have immediate access to these great slides. All right, so the first question that we will pose is, why would hospitals choose early downside risk?
Okay, yeah, that's a question we get a lot. And a hospital who chooses early downside risk is eligible to have their physicians participate in the advanced payment model under MACRA. So it's another great way to get your physicians on board, so less documentation for them if they want to choose that APM track. However, CMS really does not expect a lot of hospitals to choose this. I think they only estimate about 3% in their modeling, financial modeling. So it's just a great, but they did want to make it optional for those who want to be a little bit more aggressive and transition towards value-based payments faster.
All right, thank you for that. Our next question comes from Cindy. Right before you got into showing your dashboard, this question popped in, and she asked, what was the risk tool called that you said a lot of hospitals were using?
Sure. It's called RAPT, R-A-P as in Paul, and T as in Tom. It's a very quick and simple questionnaire. I believe it only has maybe 4 or 5 questions. Asking your patients about their mobility. And what we've seen a lot of hospitals do is fill this out with their patients. Maybe the nurse navigator does it. Maybe someone who works at the ortho clinic when the patient is scheduled for surgery does it. And based on that score, they can talk to their patient about where that patient is expected to be discharged to. So it's very simple, and it's actually been through peer-reviewed journals and reviews, has been a very good predictor of patient discharge location. If they have 6 points or less in the tool, they have, then they can go home. If they have, I think, 7 to 9 points, then they might be able to go home, but they might need a better, higher level of care, or I'm sorry, like a SNF or home health. But if they score 9 points or more, then they will likely need a SNF. So a lot of hospitals are using this as a risk assessment tool up front. I mean, they reevaluate their patients after surgery as well, but it's a great way to set expectations. And if you just Google RAPT tool online, there's free versions out there, and it's fast to fill out too.
Great, thank you so much. I'm sure they're very appreciative of that, those details, resource access. So it looks like I'll just do a quick tap dance here in case any other questions come in. But I do want to thank our members and the healthcare community for joining the call. I also would like to make you aware of a really cool event that is being hosted on May 18th. And it's geared towards our young professionals. It's called the Professional Nights for Students, where they will cover, how to prepare yourself for a job in healthcare, as well as resume reviews. So if you know someone or if you fit that description and would like to participate, feel free to get more details by visiting their website, which is hfma-co.org. All right, so it looks like we have actually exhausted all of the questions. Any final remarks or anything that you'd like to part with our audience, Lucy, before we wrap it up?
I don't think so. Just if we have any nurses on the phone, I want to wish them Happy Nurses Week.
Yay.
And if you think of any more questions, my email is and phone are the end of the presentation deck. So feel free to email me or call me.
Perfect. Thank you for that. And I'll just backtrack right quick for those that want to just jot it down really quickly. So again, thank you to Lucy Banks of BKD National Healthcare Group. Thank you to our HFMA members and the healthcare community at large. We hope you can join us for our next installation of our healthcare webinar series. Have a great afternoon, everyone.